his hand.
Lady, good afternoon. Mr. Marsh, I have just two short topics left to cover with you. And the first is in relation to long COVID. I acknowledge that you say in your statement that you didn't in fact provide any advice or information on long COVID during the pandemic, and you've referred to guidance produced in England for the sector in July 2020. The inquiry has received evidence from the Welsh Ambulance Service, who developed an action card called Guidance for Employers to inform them on how to manage long COVID sickness absence as an employer from March 2021. Do you think anything more could have been done on a national level in England to support sufferers from long COVID in the ambulance sector?
Guidance was issued by NHS Confederation for all NHS organisations, which I know the ambulance sector followed. And the principles of the way in which we cared for staff suffering long COVID was built upon that which we already provide for staff suffering other conditions as well.
Can you provide a couple of examples of those principles, please?
Yes, so certainly staff that may be unable to undertake a full range of shift duty, so there may be staff that just can't work nights anymore, and therefore we can provide flexibility around their shifts, but also other suitable alternative employment. So there may be a particular individual that undertakes a role that is of a physical nature, maybe a paramedic on the front line, and therefore we could offer them alternative employment working in the control room. So it's less activity, less strenuous, maybe with less shift work, shorter working days, whatever was required to best accommodate their needs in order to keep them in the workplace and keep them gainfully employed.
Moving on then to the topic of mental health and wellbeing support for the ambulance sector. The inquiry has received an expert report from Professor Snooks, which touches upon the absence rates in the sector, which we've already discussed, but also the stress, anxiety and depression, which was the single biggest reason for sickness absence among ambulance staff, both before and during the pandemic. So given that data before the pandemic, should mental health support have been included in pandemic planning for the ambulance sector?
Yes, I believe it should have been, and certainly we will continue to build upon the arrangements which were in place before the pandemic and during the pandemic into plans going forward. And I know that all ambulance services have really strengthened their work in relation to health and wellbeing support for all of our staff, our volunteers and our students.
And it's right that the College of Paramedics issued guidance in April 2020 to support managers with supporting their employees with mental health and wellbeing. There wasn't any national guidance or advice on managing mental health and wellbeing at that time, was there?
Not in specific relation to the pandemic, no.
And it's also right, isn't it, that in August 2021, the chief executives of trusts in England came together to request immediate additional support for employee mental health support and that was issued until the end of 2020. Is that right?
Yes.
One of the outcomes of the pandemic has been a substantial increase in the turnover of ambulance staff and those that are leaving the profession. In your view, was enough done at a national and at a local level early enough to support the mental health and wellbeing of ambulance staff during the pandemic?
Well, the first thing I would say is that attrition levels vary quite considerably between ambulance services, and I think that is one of the factors as a result of the support that individual ambulance services provide. But I do absolutely recognise there is a lot more that we should be doing, both nationally and locally, to support our staff, for them to be able to give of their best looking after all of our patients every day, and in particular recognition of the enormous pressure that we were all under in response to and during the pandemic. And I think our staff deserve it. You know, I am enormously proud of all of our staff, our volunteers, our students, staff that had retired, that returned to work to deal with the pandemic. I am enormously proud of all of those individuals that stepped forward, often in harm's way, and gave their all to keep as many patients safe and to save as many lives as possible. So by offering greater health and wellbeing support, in part is also a recognition of everything all of our staff did on the front line and in our control rooms, and working alongside our union staff representatives as well is so important going forward.
And you've summarised in your statement what your main objectives were as a national advisor for the ambulance sector. And they were to protect staff to maintain a safe 999 service, increase capacity in ambulance emergency operation centres and crews, reduce handover delays, and mitigate the possibility of services being overwhelmed. From reflection, do you believe those objectives were achieved during the pandemic?
In the main, yes.
And Mr. Marsh, do you have any other lessons or recommendations for the future that have not already been covered in your evidence today?
Only those that I've set out in my witness statement, my lady.
Thank you. My lady, I don't have any further questions.
No, I've been asked to ask you a follow-up question, Mr. Marsh. The question is this: if you took the view that the national IPC guidance was adequate, requiring FRSMs with a dynamic risk assessment, if you were satisfied with the guidance in your role as chair of the AACE, why did you make respirator hoods mandatory across the entirety of the West Midlands Ambulance Service?
Thank you, my lady. The hoods that we made available to all of my staff in the West Midlands in 2019 were for specific airborne transmission viruses and other high consequence infectious diseases. They weren't for all patients, so that would have applied then when we got into the pandemic. The use of those hoods would have applied to those staff undertaking AGPs and as part of the dynamic risk assessment, or just plain speaking, a member of staff that felt vulnerable to upgrade to wearing the hood for all other patients. It wasn't that the hood was made mandatory for all patients, only those for AGPs and for those crews that thought the patient justified, the situation justified them wearing the respiratory hood.
I think the point being made is that if the national guidance is saying that those of your staff who, with those strict conditions, would be wearing hoods in the West Midlands, why is it that you were prepared to accept the IPC guidance nationally so that the ambulance service in, say, the South East will be wearing fluid-resistant surgical masks? I think that's the question, and Mr. Simblett's nodding.
But if the patient was having an AGP performed upon them, then they would have not been in a type 2 mask. The crews would have been wearing FFP3 if they didn't have a respiratory hood, whereas in the West Midlands we didn't have FFP3s. They'd been withdrawn. So for AGPs it was the hood, and for all other patients, unless following a dynamic risk assessment justified the wearing of a hood, then the staff would have been wearing surgical masks in the West Midlands as they would everywhere across the country.
I think I've taken it as far as I can, Mr. Simblett, thank you. Those are all the questions we have, Mr. Marsh. Thank you very much for your help, and I'm sorry we had to bring you back over the lunch adjournment. Very grateful to you.
Thank you, my lady. Thank you.
Mr. Mills.
My lady, may I please call Dr. Tilna Tilakumar?
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
shall
be the truth,
be the truth,
whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Take it.
I hope we haven't kept you waiting too long, Doctor.
Your full name, please.
It's Dr. Tilna Subandi Tilakuma.
Dr. Tilakuma, you have provided a statement to the inquiry. For the transcript, the reference is INQ 000 492278. You completed your training as a GP in December 2022.
Yep, that's right.
Prior to that, and I'm summarising, you attended medical school from 2009 to 2015. That was at Barts and the London School of Medicine, before starting your GP training in August 2019.
Yep.
In February 2020, you started a 6-month rotation with a community adult mental health team. Is that right?
Yes.
Could you just describe for us the pattern of your working day there before the pandemic?
So this was a community mental health team. I was a junior member of that medical team. There was myself, another 2 psychiatry trainees and a consultant, as well as mental health nurses, therapy staff and social workers. We had a patch, a locality that we would look after. My day-to-day work was clinics, so outpatient clinics of patients with chronic mental health conditions. We would on occasion do scheduled home visits for patients who were too unwell to attend clinics. But it was all face-to-face appointments. And then I also did on-calls to look after the inpatient mental health patients.
On the 25th of March 2020, you were at home on annual leave and you received a phone call from a consultant within your home trust. Tell us about that call, please.
Yeah, it was a very brief call. We were already in lockdown at that point, so my annual leave was spent at home. And I was told that there was a suspected COVID outbreak on one of the inpatient wards, and that they needed more medical assistance. And so I was chosen as the GP registrar to go there and assist.
For those of us who aren't familiar, can you just introduce us to the type of inpatient ward that you were redeployed to?
So this was a fairly unique ward. It was what we call a continuing care ward. So it was for patients who had complex mental health needs that would require inpatient hospital care for life, and not suitable for a nursing or residential home in the community.
When you were told that this was happening, how did it make you feel?
Wasn't surprised. We were already being informed that redeployments were going to be happening. They were happening in the acute trust close by, so I was aware from colleagues that this was happening. We were in the midst of the first wave, so I didn't really have any questions. I did just go along the next day, not knowing what was happening.
So you joined the next day, 26th of March, and you worked there until the 29th of April.
Yep.
On the day that you joined, did you receive a risk assessment about working in a ward that had COVID?
No.
Did you ever receive a risk assessment at any point you were on that ward?
No.
Did you ask for one?
No.
Why not?
I didn't realise it was a thing until it was offered to me later.
When you say it was offered to you later,
On a different placement at a different trust.
you have told us that COVID was on the ward. Were both patients and staff affected at that point?
Yes, so the ward, which was a home to long-term residents, suffered their outbreak because a small group of patients from another ward was transferred into this unit. because there was a COVID outbreak on that ward. So it seemed that they were trying to mitigate risk and move patients away from that ward, but obviously one of them already had caught it and spread it into this ward. Initially, it was one patient on arrival who had a fever. And by the end of the next week, when I arrived on the Thursday, there was 11 patients who had symptoms of COVID. Friday, it was 12, and by the following Monday, it was 15, and staff numbers had dropped day by day as well. So we had a very skeletal team.
Are you able to help us with how far below being fully staffed the ward was when you joined?
So I was told ordinarily this would be a ward that was staffed by 2 nurses, 2 mental health nurses. There would be a ward manager as well who was a senior nurse but would not be doing any clinical work. And then there would be maybe 4 or 5 support staff, as well as occupational therapists, psychologists who would come in and out to do activities. When I arrived, there was still the ward manager, maybe 1 nurse, and then just a handful of support staff. And we did rely on community staff to come in voluntarily day to day, but they were very patchy. We didn't know who was coming when and how long they would be there for. It could be an hour, it could be a whole day.
Can you describe to us the work you did during your first few days on the ward?
So when I joined part of the medical team I didn't explain, sorry, is 2 consultants who would come once a week to review their patients. Then there would be 2 ward doctors who would also come once a week to mop up anything in between. It was long-term residents, so they didn't really require that much medical input. So on the first day that I arrived, there was 1 ward doctor. They were already showing signs of being unwell when I met them. And so Friday, they called in sick. They didn't arrive. They didn't turn up, so I was the only doctor there. The consultants also were off sick or on leave. So I was trying to move the ward that functioned more like a care home into a medical ward. So I was trying to firstly isolate patients who were showing signs of COVID. They had large communal spaces. Thought about isolating them into their bedrooms, perhaps cohorting patients, because we didn't have enough staff to monitor them one-to-one each, so we were trying to see if we could cohort them. That wasn't a possibility because they had bedrooms. These were not hospital rooms that they could move between very easily. I set up sort of spreadsheets of patient lists, patient names, vital signs, charts of what we call national early warning systems, so you can score their vital signs and see who's scoring high and who needs further medical assistance. We had 1 observation machine to go around 26 patients, which we required to be wiped down in between each use, so it took a long time. This wasn't something that they would be doing ordinarily on the ward, so I had to sort of signpost them to show them what ranges were normal, what was abnormal, what needed to be flagged to me as a doctor or the nurse. It was really just trying to organise chaos.
At this point, had you been provided with any information or guidance about how to treat a patient with COVID-19?
No. Nothing from the trust. It was all sort of word of mouth from my colleagues in the main hospital. It was largely supportive. There was nothing else we could do in our healthcare setting anyway.
In terms of how the patients responded to some of the measures that were implemented within the ward, you divide them, I think, into 2 groups. Can you describe to us the two types of response that you perceived from patients?
So these were patients with chronic mental health issues. So a large majority of them were, how I could describe as subdued, would be compliant with instructions to stay in their rooms, hyperactive, quiet. And then there was a group who was more restless, more agitated, and that includes the 6 acutely mentally unwell patients who came from that other ward who needed psychiatric input. One of them in particular was very agitated, definitely couldn't be kept in their room, would often be walking around, coming very close to you, breaking that 3-meter rule, would never wear a face mask, could spit as well.
For those sorts of patients, what level of staff supervision was required?
We didn't try to restrain this patient. For his mental health, he probably needed one-to-one observation just to make sure he didn't come to harm himself. When he was particularly agitated, perhaps 2-to-1.
Moving to a different topic, you say in your statement that almost immediately upon joining the ward, you began to have phone conversations with family members of patients who were identified as potentially not surviving severe illness with COVID-19 as a result of their comorbidities. Are you able to describe in general terms the nature of those conversations?
On the whole, they went well. In my experience, they all went fine. These were long-term residents, so the families and of these residents knew the staff, and, were happy with their care, and trusted staff, and so there was good communication and rapport with them already. They knew what was going on nationally. They knew what was going on the ward in terms of the outbreak that we had here, and that more and more patients were becoming unwell every day, and staff were going off sick. So they were very understanding. My conversation with them was more anticipatory. So did they already have ideas? Did they already have wishes that they knew their loved one had about whether they would want to be admitted to hospital? Should they become unwell? Would they want resuscitation? If not, if some of them would have had wishes to die in their own home, which was this ward. Some of them made requests for specific music to play if they should be unwell and pass away on the ward. So yeah, it was. I know it was difficult for the staff to have these conversations because I think it was nothing that they would have been planning for anytime soon. These weren't particularly elderly patients.
Did you personally feel equipped to both have the conversations and cope with having had them?
Because of my experience before GP training, I had done quite a few years in geriatrics already, so I did feel comfortable having these conversations, but it's always difficult when it's a patient you don't know, relatives you don't know, and doing them over the phone and not face-to-face is very difficult.
Can I ask you about PPE and IPC guidance? When you arrived on the ward, what were the standard PPE requirements that you were expected to wear?
I don't know if it was a guideline or guidance, but what was happening on the ward was that everyone was wearing full PPE, so that was a surgical mask, gloves, apron, shoe covers, at all times everywhere on the ward. And then at some point within the next week, we were downgraded to only having to wear that when we're in contact with the COVID patients.
I'll ask you about the downgrade in a moment, but first can I ask you this? That was the requirement for what ought to have been worn. Was the PPE always available?
Initially it was. When I first started, towards the end of March, we had PPE that was accessible.
It sounds like you're about to say that it then wasn't.
Yes, when it was downgraded to only being used with COVID patients, then it became very hard to actually find where they were and replenish stock.
Were there instances of staff having to source their own PPE?
Yes, so so a lot of us used our own scrubs. I borrowed some scrubs from the neighbouring trust, an acute trust. We bought visors and goggles off the internet. That was something that we asked for. That wasn't included in the original PPE that we had, but we needed that specifically for our cohort of patients who could come very close to you, spit. So we did end up buying those ourselves because they never came from the trust.
Were you reimbursed?
No.
You have referred to the downgrade. Can I ask you this? How were the changes in that guidance communicated? How were you told that the PPE you had been wearing was in effect no longer required?
Verbally. So we would get visits from managers to the ward on a daily basis, different managers, different roles that we didn't always understand. But we would be communicated verbally, or it would be through maybe a Teams call to our ward manager and our ward manager to us on the ground.
Toby, sorry, I'm going to have to rise.
Rise.
Sorry about that, everyone. I suppose if you are going to feel sick, you might as well do it with the GP in the witness box. Everyone stay away from me is all I can say, but I think I'll be all right. If I make another rush for it, you'll all know what's happening. But
Thank you,
go as far as we can.
Dr. Tilakumar, you were just explaining the communication of the downgrade in PPE requirements. Can I ask you this? Having become accustomed to wearing a certain level of PPE, and that level being downgraded, how did you and the other members of staff on the ward feel about your safety?
As far as we were concerned, nothing had changed in our clinical environment. We were still dealing with at least 15, probably more patients with COVID at that point. None of them were not all of them were being successfully isolated at that point. So there was no guarantee that we could contain COVID to bedrooms. So the entire ward was a COVID ward as far as we were concerned, and PPE needed to be worn at all times. And I know some staff members did continue to wear PPE at all times. And there was an incident where a visiting manager did come and see a healthcare assistant wearing a plastic apron, and she pulled it off her. And the healthcare assistant was black and the manager was not.
Because the healthcare assistant was wearing that apron somewhere where the guidance said you do not need to?
Yep.
Can you tell us about your experience of being fit tested for FFP3 masks?
So this was something that I was asking for and was being rolled out at the trust anyway. On Friday, the 3rd of April, we had fit testing on the ward. I called in my colleagues who worked in other places in on the site to come to the ward and have fit testing, and then we realised they were using FFP2 masks. So I told them to stop. And we did later have FFP3 masks tested at various points over the next few weeks. I failed on 2 of the masks and I passed on a 3rd. That was by the end of April.
Can I just check, are you using FFP2 in the same sense as the previous witness, the blue mask that we all got used to seeing? Or do you mean the actual
there was a
specialist FFP2, which is one step down from the FFP3?
Yes.
Okay.
Did you ever have a day where you wore an FFP3 that had been fit tested correctly to you?
No. We were told they really only need to be used during aerosol generating procedures, so that was only CPR. So I didn't have to wear it in any case in the end.
Before you had your successful fit test, you've just touched on it in respect of CPR. It's right, isn't it, that you had a serious concern about who might be able to perform CPR on the ward?
Yes, I mean, all our staff are trained in CPR, so we could all initiate it. But as the doctor, especially on call, you would obviously be looked to be the one who would lead the basic life support until paramedics arrive.
Did testing become available whilst you were working on the ward?
Testing for staff was available if you were symptomatic. That was across the trust, which covered multiple sites, and there were only 35 tests available a day. Tests for patients did come in at some point, and that was being done on a weekly basis once we did start.
Did you ever receive a test?
No, I didn't show any signs, so I never had an antigen test. But I did have the blood test for PCR antibody done in May. That was being done by my other trust that I was employed by. And I tested positive for antibodies, which did suggest that I had been exposed and had a reaction to COVID.
During your time on the ward, I think it's right, isn't it, that you requested that you and your partner be moved into hotel accommodation. Can you tell us about what prompted that request?
Both. So I was working on a COVID ward, and my husband was working in A&E at the time at a different trust. We were both living with my parents at the time, who were both in their late 60s. It initially didn't occur to me that we would need to probably shield from them, or they would have to shield from us. But as time went on and I realised how serious COVID was and how prevalent it was on our ward and how I couldn't really keep myself safe from catching it, or nor my husband, we asked for accommodation to shield my parents.
Was it provided?
Yes.
How long did it take?
Maybe a week.
We heard some evidence this morning from a paramedic who was living in a hotel. Can you tell us about the impact that living in a hotel had on you and your husband?
It was a very basic hotel. But definitely not meant for long-term living. There was no... we had food provided to us by the trust, so we had 3 meals a day provided from the canteen. So we were provided for, but we apart from a kettle, we didn't have anything else in our room, and laundry was difficult.
The concerns that you have told the inquiry about this afternoon were things that you raised eventually with the Trust, is that right? What, if any, response did you receive from management after you raised those concerns?
So I raised concerns throughout the time that I was on the ward from the very first. So I joined on a Thursday, and over that first weekend, I drafted a very long email and I sent it out to everyone that I could CC in, everyone I could think of in the Trust. And this chain continued for over the 5 weeks that I was on that ward. I did get more medical help, so I got 2 other doctors redeployed to join me on that ward by the next week. But other than that, my requests for another observation machine didn't come. My request for more PPE was patchy. For other staff members was, as I said, voluntary, on a voluntary basis, so there was nothing consistent. Other bits of equipment that we asked for, a syringe driver for palliative care medication, was difficult to come by. And in the end, the communication was getting a bit more difficult by email. And then in the end, I was referred to speak to our Freedom to Speak Up champion at the Trust. And this was towards the end of April.
And are you able to tell us about the conversation you had with the Freedom to Speak Up champion?
Yeah, it felt very open and very friendly. We spoke for quite a while, maybe half an hour to an hour, and I laid out all the summary of all the things I'd been asking for that the ward still needed. Equipment, more staff, better well-being facilities for the staff. At that point, I still hadn't been fit tested, so my fit test was organised the next day. But then I was also just moved back to my original placement for the next day as well. The other 2 doctors were not.
When you returned to your previous, this is the community role, isn't it? On the 29th of April, in what ways had that role changed since you left it in February?
So it was mostly remote working. Everything was being done by phone, so all our appointments were by phone or video. My consultant was shielding, so I never actually saw him again in the flesh. So all my supervision was done remotely. There had to be 1 doctor on the team available on site, so me and the other 2 doctors had a rotation to go into the office. Otherwise, we worked from home with laptops.
Did you feel as if you could provide the care you wanted to patients remotely?
I don't think our number of appointments went down, but telephone and even video consultations does form a barrier with patients who already have mental health difficulties. So in that way, I'm not sure how effective the consultations were.
Was it possible at that time to arrange face-to-face appointments with certain patients?
Not straight away. I think the clinics were still closed. We could do home visits still with PPE provided to us. We could go out and see patients if we needed to.
You then, I think in August 2020, began a rotation in obstetrics and gynecology. Is that right?
Yep.
Whilst you were there, did you perceive the impact of visiting restrictions on patients receiving maternity care?
Yes. So pregnant people were not allowed to bring in anyone else to their antenatal appointments, so they would attend alone. There was no visitors allowed on the antenatal ward, and only one birthing partner allowed in the birthing suites, which are obviously private suites. And then again, when they went back to a postnatal ward, no partners were allowed, no visitors were allowed, which was hugely impactful for new parents.
In March 2021, you rotated to general practice for the first time in your training, is that right?
Mm-hmm.
Can you tell us about the IPC measures that were in place at the surgery where you were?
We had, we were doing everything remotely at that point in March 2021. It was all video and telephone calls. If we had to bring anyone in, it was, every practice would be different on this, but our practice, we had one room that was available to bring in patients if you needed to see them, and you would wear full PPE, which was apron, gloves, and a surgical mask, the blue mask. We did have a visor as well.
The patients that were attending the surgery in March 2021, were you able to perceive whether there had been a real downturn in their physical health?
So I've never done general practice before the pandemic. I wouldn't know how to compare the population before and after. But everyone who was asking for an appointment needed an appointment. Yeah.
Did there come a point during 2021 when you were offered psychological support?
Yes. This was through my GP training program. We were offered, we still had once a week a half-day teaching session as a group, and during one of those sessions in 2021 we were offered sort of a breakout group for those who, it was optional if you wanted any kind of debrief about the COVID pandemic. We were offered a psychologist there, so it was a bit of a group session, but during that session the psychologist suggested that I probably should seek further counselling because it might be possible that I had PTSD from my time working on the COVID ward.
And did you seek that further counselling?
I did. I went through occupational health and had a consultation, and I was told that I probably didn't have PTSD, but I could self-refer to the Trust's counselling service, which I didn't do at the time.
Is the impact of working during the pandemic on your mental health something you still feel today?
Yes, I didn't have any problems with my mental health before the pandemic. I also didn't have any problems working with my mental health before I started working general practice. So I don't know if it's a combination of working in general practice in a post-pandemic world, which has resulted in me having now 2 episodes of depression. Mostly from working in isolation, feeling burnt out, feeling that lack of satisfaction in my work, that I don't feel I can really help patients when they come asking for help in the NHS these days.
Dr. Tilakuma, thank you. My lady, that's all I ask.
Thank you very much indeed. I'm really sorry to hear about the depression. I hope the physician has tried best to heal herself, but I appreciate it's not something you can heal yourself, and I do hope that you do recover from it in the fullness of time. So thank you very much for what you did, and thank you for helping the inquiry.
Thank you. Thanks.
Thank you, my lady. May I please call Professor Catherine Rowan? I'm being told we just need to wait 2 minutes, if that's okay. Apologies.
Don't think it's your fault, Mr. Farman.
Just a courtesy.
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that the evidence I shall give
shall be the truth,
the truth,
the whole truth,
and nothing but the truth.
Okay, take a seat.
Professor Rowan, I think you may have had to make some rearrangements to come here this afternoon. I'm really grateful to you. We try to get everything organised well in advance, but sometimes changes are made. So thank you for your help.
My lady.
Your full name, please, Professor Rowan.
My full name is Catherine Rowan.
Thank you. You have given a witness statement to Module 3, dated the 23rd of May 2024. That's INQ 30480139. Can I check that you are familiar with it and you have a copy available to you?
I do.
Professor Rowan, you are the founder of the Intensive Care National Audit and Research Centre, known by the acronym ICNARC. That's correct, isn't it?
It is.
You were a director of ICNARC from its inception in 1994 until September 2023, and you remain a scientific advisor today.
I do.
You are also an honorary professor at the London School of Hygiene and Tropical Medicine.
I am.
And you are a programme director at the National Institute for Health and Care Research.
I am.
Professor Rowan, today I'd like to cover, first of all, a bit about ICNARC. I then want to ask you about some of the work that you've done for the inquiry. And we're then going to ask about some of the specific analysis within those reports, particularly in relation to patient admissions, critical care transfers, then some of the pressure that was on intensive care units, and some of the specific characteristics of patients in intensive care units. So hopefully that's all clear for you.
It is, thank you.
You set out in your witness statement that ICNARC is an independent, scientific, not-for-profit organisation which works to facilitate improvements in structure, process, outcomes and experiences of critical care. And it does so through clinical audit and research programmes, is that right?
That's correct.
You also describe something called the Case Mix programme. Can you tell us briefly what that is and how it works?
Sure. So the Case Mix programme is a national clinical audit of adult intensive care or adult critical care. And essentially, the purpose of it is to monitor care and the outcomes of care across different critical care units. So the way it works is that we have specified a data set to be collected by units. It's a mix of electronic data capture and data collection by hand. And those data are sent to us on a monthly or quarterly basis. They run through a large number of validation checks to get the data as accurate as possible. And then we provide quarterly quality reports, which contain various indicators around the delivery and outcomes of care to compare units with each other, but to actually sort of benchmark across units with a view to allowing units to sort of look at their practice and also to institute sort of local quality improvement programs. We also use the data, the pooled data in the database, to, as transparently as possible, to try and help patients, clinical staff, managers, policymakers to understand critical care and sort of inform best management, best sort of operation of critical care.
You've touched on it just now, but just to be absolutely clear, who do your reports actually go to?
So the reports go back to the critical care units that submit the data. But within those reports, they can see and identify their own data or their own outcomes or their own indicators, and then they can compare them with all other critical care units, but also critical care units that are deemed to be similar to them in operating characteristics.
What about national decision makers, for example, NHS England or the Department for Health and Social Care? Do your reports go routinely to those organisations?
So the quarterly quality reports don't, but we operate a policy whereby once a year we publicly report a sort of a global state of intensive care in the UK, critical care in the UK. But we also have a very close working relationship with NHS England and the NHS sort of organisations in the devolved nations, and also the Department of Health and Social Care. So it can often be on a sort of an ad hoc basis that they may request reports, and we will undertake those analyses for them.
One point which is worth clarifying is I understand the Case Mix programme applies in England, Wales and Northern Ireland, but not in Scotland. Is that correct?
Yes, I think that's possibly by dint of history. The Scottish Intensive Care Society Audit Group with Public Health Scotland run the Scottish audit, which I think set up the year before us. And it's just sort of by dint of that history that we have a scope or reach for England, Wales and Northern Ireland.
But you and the Scottish Intensive Care Society Audit Group, SICSAG, do almost identical things, is that correct?
We do almost identical things, absolutely, but certainly one of the lessons from the pandemic was we don't collect exactly the same data. And I'm pleased to say that one of my new co-directors today is actually up at SICSAG discussing perhaps one of the lessons from the pandemic, which might be trying to make sure that we collect compatible data going forward.
Focusing, if we can, just on, for the moment, your data.
Yes.
Is it right that all NHS general critical care units in England, Wales and Northern Ireland providing level 3 care I think level 3 care is typically care that involves one-to-one critical care nursing, usually with mechanical invasive ventilation. Is that right?
That is correct.
All of those critical care units, you get all of the relevant information
Yep.
within the case.
We have 100% coverage of those.
So you have a very
we-
comprehensive picture with respect
Yes,
to those particular
indeed.
critical care units.
Yes.
Thank you. Did you specifically create COVID-19 related data collection sets during the pandemic?
We did not, and the reason we did not was really from the lessons that we learnt a decade earlier with the H1N1 sort of epidemic, where we did try and identify a sort of bespoke additional data collection. And of course, at that point, the system's not ready to adopt new data sort of systems, new data structures. And the lesson we learnt was to do the best we could with the data that we currently collected, rather than to try and burden an already burdened system
With additional requests?
with additional data collection.
You did, though, collect data on patients with patients with COVID-19 who were admitted to critical care.
So again, one of the learnings from H1N1 was that we created within the new data set following that sort of some temporary fields which could identify should another epidemic or pandemic come along, we would be able to kind of tag those patients. And we opened those fields up, which I'm sure is not the technical term. I'm not a data or technology person. At the beginning of the COVID-19 pandemic, to make sure that we would be able to identify suspected and confirmed COVID-19.
You also, I think, as a result of that work, were able to send, in addition to the reports we spoke about before, daily emails, I understand, to Professor Stephen Powis and Sir Simon Stevens at NHS England, updating them with respect to the numbers of patients with COVID-19 admitted to critical care units. Is that correct?
It is correct. The way that we did that was because we're aware of the burden of data collection, we asked the units, and I really should shout out for the amazing network of audit clerks within the critical care units across England, Wales and Northern Ireland, who managed to keep up these data collections throughout the pandemic. So what we did was sort of stagger the data submission so they could tell us about numbers daily, and then they could sort of fill in the first day's data and then the full stay data at later stages. So it meant that we could just keep on top of the numbers that were being admitted to critical care on a daily basis.
For how long did you continue sending those daily reports to NHS England?
Daily throughout the whole pandemic. So clearly,
That's
as
fine in terms of just
waves dropped, it might have been less frequent.
That's fine, just to get a sense of the period in which you were doing that. And did you send any specific reports similar to this or identical to any of the officials within the devolved nations?
No.
Do you recall ever receiving requests from any officials within Northern Ireland or Wales for similar reports?
Not for daily reporting, but we did produce reports as requested for both Wales and Northern Ireland, just as and when they requested them.
Thank you. To turn now to what the data itself is showing us, ICNARC has very helpfully produced 2 bespoke reports for the inquiry. One of those reports was produced solely by ICNARC, a lengthier report, and then a combined report that was compiled alongside CICSAG, who we were just speaking about. I understand you're familiar with both of those reports.
I am familiar with both the reports.
Just for clarity, with respect to the joint report, you weren't involved in any of the data collection from ICNARC's perspective with respect to Scotland, but that data has now been compared and made, and the relevant checks have taken place to ensure it's compatible with the data you collected for England, Wales and Northern Ireland. Is that correct?
The 2 analytical teams worked closely together to ensure that there was consistency and standardisation before that report was produced.
As a result, you're able to speak to the joint report.
I'm happy to speak for the two reports,
Thank
yes,
you.
or the combined report.
Just precursor to us starting to look at this data, we're going to go to a lot of graphs, so just going to headline that. What the graphs will show us, generally speaking, is a period 2 years or so prior to the pandemic, and then our relevant period for the purposes of this module, which is March 2020 to June 2022. And that, as I understand it, was done in order to give us a reasonable comparison period. Is that correct?
So I think the inquiry, in discussion with us, agreed on the periods, but absolutely it was about a sort of a stable period of what sort of usual critical care looked like beforehand, and then moving into the period, the relevant period determined by the inquiry team.
If we can now go to the first graph that I'd like to take us to, that's INQ, oh, it's already on screen. I'll say it anyway. INQ 307474239. What we should see here, I hope, is a graph in relation to mean daily patients admitted to critical care. Are you able to explain what this graph shows us?
Yes, absolutely. Let me take you through it. There'll be lots like this, so maybe I'll just take a period sort of. So along the bottom, along the horizontal, are in weeks. So each line represents a week, and the data are daily, but average daily for the given week. And you can see the period up until the sort of dotted horizontal line around the middle, which is what you might call the pre-pandemic period. It's identified there. And then what we would call the relevant period to the right of that line, which is the period for the inquiry and obviously the period of the COVID-19 pandemic. On the vertical axis, you can see it says mean daily patients admitted to critical care, United Kingdom. And this is from the, I think, joint report.
This is from the joint report.
And what you can see is usual critical care is about approaching 600 mean daily patients admitted to critical care. And then to the right of the line in the relevant period, you can see there's a quite substantial drop in the mean daily patients admitted to critical care. This feels slightly counterintuitive because we think about the kind of, so this is daily admissions. And so what you can see is that because critical care, COVID-19 patients in critical care were staying at the beginning about 17 days in critical care. It reduced down to about 14 as it sort of stabilised and sort of treatment became a little more understood. And that compares with all other patients, which is a mix of planned patients, elective patients, and unplanned patients. Unplanned patients normally stay about 7 days, and elective and planned patients about 4 days. So you basically have a lower admission because the beds are full with these very long-staying patients. And as you can see, after each wave, you can see the kind of slight recovery in terms of the numbers of all other patients. And that's sort of the opening up of elective and planned work again. And then when the next pandemic wave hits, that elective and planned work drops off again.
So focusing just on daily patients admitted to critical care, and obviously the emphasis being on patients admitted
Yes.
each day,
Yeah.
we can see that there was a drop, as you've touched on. You touch on the lack of elective care potentially impacting on daily admissions. Are there any other reasons that may have impacted on?
So just capacity. So there was a decision to help the health service by sort of stopping, and people will be aware of operations being cancelled and other sort of planned care perhaps not happening with the same frequency. The other thing that this graph doesn't show is that there were critically ill patients being managed outside the intensive care units. So these are patients admitted to critical care. These are not patients who are critically ill. And there would have been a larger number of patients sort of outside the critical care units who were critically ill and being managed And you heard, I watched Professor Kevin Fong's testimony, and you heard about the challenge of that sort of management of patients.
So just to pick up on that, those patients who may be in what may sometimes be termed surge areas,
Yes.
or areas in which they're receiving high intensity care, albeit it's in a general ward or a non-ICU environment, those patients wouldn't necessarily be picked up by this graph, is that
So
correct?
we had some coverage of surge units, but it was really down to the local hospitals and their ability to extend their data collection to those areas. But as I understand it, there was a lot of delivery of what you call non-invasive respiratory support outside critical care units, and a need for invasive respiratory support was obviously a key, or other sort of complex organ support.
What about patients potentially staying at home and simply not attending ICUs?
So in terms of sort of the pool, yes, there's a whole journey you need to think of. So you need to think about the people at home on their own who maybe had unwitnessed heart attacks, who in normal circumstances might be witnessed and make their way to hospital and hopefully their way to intensive care. There was some notion that trauma cases reduced during lockdown because people weren't out and about having traumatic injuries. As I say, there was a reduction in sort of stopped elective surgery and other sort of more planned procedures. So the pool is changing. And then there was hesitancy, and this is just, I believe, in terms of, seeking access to hospital. There was a sort of a stay at home, help the NHS, and that may have changed healthcare seeking behaviour.
So a variety of factors, some of which we can't see from the data alone.
Not from intensive care data per se.
That can come down for the moment. We don't need to go to it, but you have also included in your report messages about all of the individual nations of the UK and how they were affected. The headline message, I think, is that there were similar patterns in terms of mean daily admissions.
Patterns were incredibly similar across all four nations.
We do now need to go to another graph, though, which is INQ 304742339, page 9, and this is figure 3. What we're going to look at now is the daily number of patients actually in critical care, as opposed to the number of patients who were admitted. So if we could get that up, please. Yes, so we should see here what I was just talking about. Can you now explain, I think you touched on it a little bit before, but what the differences are?
So we can remember from the last graph that pre-pandemic there were 600 patients admitted, mean daily patients admitted. And this now translates to, in the pre-pandemic, in more normal times, about 3,000 admissions in intensive care on any sort of given day, or averaged over sort of days into the week. And I think this probably now feels a little more familiar, if that makes sense. So as we move, I'm not going to explain the axes again in that the graphs are so similar, but do ask me if you want me to. So what you can see here is, again, that line moving into the relevant period. And that initial drop-off is actually probably the stopping of elective work. And then you see the peaks of the waves in orange of the patients admitted for COVID-19. And you can see it's more than half the caseload in critical care in both the first and the second wave. The third wave, as you sort of got to Delta and Omicron, the other thing to just bear in mind, around February 21, vaccination starts to kick in. And, one of the thankful things about the vaccination policy and rollout was it did reduce the numbers getting really sick with COVID-19, and therefore the demand on critical care did reduce in those later waves.
Tying together what you told us before, and you touched on it briefly, are we correct to draw from these two graphs that, in fact, the pressure on intensive care units was not caused by a significant increase in the number of admissions and individual patients coming into ICU on a daily basis, but as you said, patients spending a lot longer in ICU, and during peaks of the pandemic, many of them doing that.
It was the numbers in critical care. So the reduced admission rate is because there's sort of no free bed to put them in. And again, you've heard that a bed is not a bed is a skilled nursing colleague and other allied health professionals, and they're simply, you heard how stretched they were, and you can see how much they've increased their capacity. There was a lot of sort of stretching to try and deliver care to as many people as possible.
Even with the caveats that you provided before about not covering all surge areas, you can see significant increases during the peak.
Massive, yes, and the numbers are not accurately known for the numbers who were critically ill and managed in surge areas that we didn't cover.
Can I ask you, that can come down for the moment, can I ask you, Professor Rowan, about something you say in your witness statement at paragraph 7.3, and I'll just read it out. You say this: overall, approximately 24% fewer patients were admitted to critical care for reasons other than COVID-19 across England, Wales and Northern Ireland than would have been expected based on pre-pandemic rates of admission. You then go on to say it's impossible to determine exactly the causes for that. Sorry, I'll bear with you. It's paragraph 7.3.
Yep.
So did you hear what I read out?
I'm sorry?
Did you hear what I read out?
Could you just repeat that for me? I'm sorry, I got a bit distracted about finding the page.
That's okay. You say overall, approximately 24% fewer patients were admitted to critical care for reasons other than COVID-19 across England, Wales and Northern Ireland than would have been expected based on pre-pandemic rates of admission. So we've obviously just looked at admissions, and both in terms of the number of patients coming into ICU and the number of patients actually in ICU. Given what you say about there being approximately 24% fewer patients for non-COVID reasons, are we correct to assume that there are potentially a number of patients with non-COVID conditions who we would normally have expected to come to ICU who simply didn't for one reason or another?
Without the information, without the data on, if you like, the pool of patients in hospital. So what we do know, very early on in the pandemic, we did a report that was part of my witness statement around what kind of gains could there be made in capacity in critical care by the cancellation of elective and planned work. And that amounted, I think, from my memory, to about sort of 22% of bed days that would not be occupied. And therefore, some of this will be the cancellation of elective sort of unplanned work. But I think it wouldn't account for all of it. I think if we look across the whole pandemic period, there was probably about, if you cover all the waves, probably about 9 to 12 months of stopped or cancelled elective work, because obviously it recovered between the waves. So that would have been some of it, but probably not all of it.
That's very clear, thank you. Touching on what you touched on earlier, the fact that there was a considerable difference in terms of the average length of stay of a patient with COVID-19 and a patient for all other reasons. I think you said something like 17 days in the beginning for a COVID-19 patient. We heard yesterday from Dr. McConnell, who is the former medical director at the Western Health and Social Care Trust in Northern Ireland. And she spoke about some very lengthy stays in ICU in Northern Ireland, particularly in her trust, in, I think, the Omicron period. I'm not sure entirely, but we have a particular graph which ICNOC has produced in relation to length of stays in Northern Ireland. So if we could just go to that, please. It's INQ 3080138, and we're looking at figure 96, please. So if we're just looking at this graph, it looks as if you mentioned before something to the effect of 17 days in the beginning, and then a reduction in the length of stay of COVID-19 patients. But if we look at January 2022 here, it looks as if in Northern Ireland there is a significant increase, is that right, in January 2022 to almost double what it was even at the beginning on average?
So you can see that there are gaps in the orange line because we don't report for small numbers, so for those sort of months where there were fewer than 10 admissions. And the numbers are smaller in Northern Ireland, and also less were going into intensive care in those later waves. But there's no two ways about it, that when you do an average, obviously you're doing an average, but it's very skewed by longer staying patients, and that will have a bigger impact on a smaller number of patients in the sum, if that makes sense.
Sorry, so is the explanation for this that there were a few, as it sort of says in the headline, there were a few patients who were spending significant...
who will have dragged the average up. That doesn't mean that those patients did not have those considerable long stays, but it means that it may have dragged the figure higher than what would be the sort of what we might call more normal stay for those patients. Does that make sense?
I think it does, but it makes it very clear that there were some patients having potentially
Absolutely.
extraordinarily long stays in ICU, particularly in Northern Ireland in January 2022, which makes it quite surprising.
So the other thing to just bear in mind is when we get to Omicron, the population is more vaccinated, let's say, or more highly vaccinated than in those earlier waves. So the patients now getting into intensive care come with much greater other sort of advanced chronic conditions. So these are people who, despite vaccination, COVID is a significant hit and requires their admission to critical care. So it's sort of a much more complex, a much sort of different patient to earlier pre-vaccination, where it was a disease that in its own, in isolation, would bring you into critical care.
I appreciate that you necessarily have to caveat things in terms of only being able to infer what the data says, but would that also coincide perhaps with the fact that those patients may have been shielding previously?
That I don't know.
Okay. That can come down, and I want to ask you about critical care transfers.
Yes.
So this is 474239.
Just before we move on.
Oh, sorry, would you like to take a break?
Well, I was just thinking that might be...
Yes, a convenient time, yes.
If you're going to different subjects.
No, definitely.
We take regular breaks, Professor Owen, so I shall return at 3:25.
All rise. All being well.
Mr. Farman.
Thank you, my lady. As just mentioned, we're going to move to critical care transfers and look at INQ 30's 474239. We're looking at figure 9 here. Similar sort of graph to the ones we were looking at before. Can I hand over to you to explain a bit about what we can see here?
Sure, absolutely. So again, you've got that pre-pandemic and then the relevant period, and then you've got the mean daily transfers between critical care units.
Sorry, can I just pause you, in fact, to just explain what critical care
I'm sorry,
transfer
yes,
is?
absolutely. Forgive me. So these are the transfer of patients between critical care units in different hospitals. So they don't include sort of movements within the same hospital, which was about managing care, under stress and whatever. But this is where patients have to be put in a transport vehicle with a team and taken to another critical care unit.
Thank you. If we can go back to what the graph shows us.
Okay, so I think of others have indicated that the provision of critical care beds in the UK relative to similar OECD countries is low. So we have, capacity issues and therefore there are transfers between critical care units. At the bottom there, the repatriation, that's very often where perhaps you're moved to another critical care unit further away, sometimes for good reasons, for more specialist care, sometimes for not so good reasons, which is being moved because there's no room and for capacity issues or comparable care. But repatriation is coming back to a critical care unit sort of near where you live. So some of those can be for good reasons.
Sorry, just to clarify, the repatriation is going back to somewhere that is closer to perhaps where you live.
So,
you had an accident or something.
if you've been moved from your original critical care unit, it's a return to the critical care unit. As I say, that move may have been for more specialist care, or it may have been because of capacity issues and therefore for just comparable care in a unit with space.
Sorry, just to be absolutely clear, I think because we're getting a bit confused in terms of the words, I think, am I right to think that it's the other reasons that might be for comparable care?
So those are in the
specialists,
orange.
And the repatriation
Yes.
is for care that may
Yes,
be closer
absolutely.
to your home, for example.
Yes, absolutely. So what you can see here is there's about 20 mean daily transfers between critical care units in the pre-pandemic period. And then during the first two waves, you can see this threefold and fourfold increase in the number of inter-hospital transfers during the first and second wave. And because of the differences between the case mix program and the ZigZag data, we weren't able to sort of
Break down further.
break down the other reasons further. As I say, patients were being transferred for ECMO and very specialist services that are centralised, but a number of these were, as we heard from Kevin Fong, around helping units manage, particularly units manage an overburden of patients and moving them to units that
May have had capacity, is
had
that right?
space.
As you touched on, you couldn't, for data comparison reasons, get this data in terms of the breakdown of those other reasons for the whole of the UK, but you can for those in the case mix programme and in
Indeed.
Wales and Northern Ireland. So I'd like to look at those so we can see some of the breakdowns for the reasons for critical care transfers.
Indeed.
This is on, in your own report, figure 13. It's INQ 30s 480138.
So again, you can see consistency between these because the dominance of England, Wales and Northern Ireland, the Scottish data only bring a few more numbers, but you can see that pre-pandemic there's about 20 mean daily transfers. And again, now what we've split here is you're worried about the orange ones. That's just being transferred for comparable care. More specialised care is because for certain techniques that are not needed all the time, it's quite right to centralise those, so something like ECMO, where skills are actually enhanced in delivering that care, and patients would be transferred for more specialist care. That's in the sort of bluey-grey. And then again, you can see the repatriation. And I guess the alarming bit for me is you can see that the big uptick in the inter-hospital transfers between critical care units is predominantly in that sort of comparable care. And while, a transfer, when it's necessary, can be done safely, it does come with a risk to move a critically ill patient, and it comes with a burden of resources that, as we know, were probably needed back in the original transferring unit. And there were sort of specialised transfer services sort of established during the pandemic to try and meet some of this demand. But again, you can just see these huge increases.
So just to tie up what you were saying, are we right to conclude, generally speaking, that transfers for either of the two blue reasons, repatriation or more specialised care, may be clinically appropriate, whereas transfers for the orange comparable care reason would indicate that was driven by capacity concerns rather than clinical need?
And ideally, you would like to see none of those pre-pandemic, and certainly not to be forced into the situation we found ourselves in during the relevant period of the pandemic.
we should recognise that there are some transfers for comparable care pre-pandemic, though, aren't there?
Indeed. But you can see the large increases in the relevant period of the pandemic.
I'm going to, that can come down now, thank you. I want to ask you about, within the context of pressure that's been put on critical care units, having looked at admissions, both number of patient admissions on a daily basis and also patients in critical care and critical care transfers, you talk about a concept in your witness statement at paragraph 6.1, which you have termed ICU capacity strain. Are you able to explain what that term is and where it comes from?
Okay, so even during normal times, critical care, particularly over the winter season of flu and other pressures, sees situations where demand outstrips supply. Demand being, let me just make sure I've got this right, the number of patients who you want to provide critical care for, and supply being the available beds to deliver that care. So we wanted to look at that, and we did look at it some years back, and we showed that we created a sort of a concept of the number of patients in the unit as you are admitted, sort of tells you how busy the unit was as you were admitted. So for every patient in every unit, you can get the sort of a concept of were they admitted on a typical day or were they admitted on a day that was lower than typical in terms of number of other patients in unit or higher than typical sort of type thing. So the notion being that your first day in intensive care is very important in terms of setting up your care, and I'm talking now pre-pandemic, equally so post-pandemic, during the pandemic, but pre-pandemic. And what we showed with careful analysis and adjusting for the confounding factors of the types of patients and that kind of thing was that patients who were admitted in periods of higher capacity strain were less likely to survive.
That was work that you started pre-pandemic.
That we did pre-pandemic.
Am I right? You then did some further work to adapt that model for the
So
pandemic.
then we found ourselves in the situation where during the pandemic, we hadn't seen such strain on intensive care units. So not unlike the comparisons here, we took a period for each intensive care unit to understand their typical, numbers of admissions daily. And then we took the period of the pandemic and we identified each patient as being admitted again at the normal or typical sort of number of patients in the unit, lower than that, higher than that, but then we created this sort of pandemic high and pandemic extreme. Pandemic high was you were admitted at a period that was 10 to 50% higher. Pandemic extreme was the unit was greater than 50% fuller than normal. And in that situation, again, we carried out a very careful analysis, adjusting for the types of patients. And what we showed was, and I just will read this to get it absolutely correct.
Yes, I wonder, Professor Owen, if we have on screen perhaps your paragraph 6.4, it might help.
Yes, that would help. Thank you.
And
Thank you. So the bit I'll read from is for COVID-19 patients admitted during periods of pandemic high. So that's where the unit sort of anything greater than 10% but less than 50% fuller than typically, or pandemic extreme greater than. ICU capacity strain during the first wave, we found no difference in hospital mortality for COVID-19 patients. In the second wave, we found a 17% increase in the likelihood of dying for pandemic extreme. So pandemic high and pandemic extreme was about 15%. They're quite similar figures. For non-COVID patients, so alongside the COVID patients at this time, there are patients being admitted not for COVID reasons. There was a 16% increase for pandemic high and a 30% increase for pandemic extreme so this is a 16% increase in not surviving to leave hospital alive, or a 30% higher overall odds of acute hospital mortality when compared with typical capacity strain. So what this sort of suggests to me was the reason maybe that we didn't see it for COVID patients during the first wave was all the attention that was being placed on, the delivery of care to COVID patients. And I felt, we've all heard that what our clinical teams were under in terms of that. But then the kind of more balancing in the second wave and subsequently, whereas to be a non-COVID patient in that first wave or in that second wave, which were the two waves that we studied, there was a notion in which, once again, with careful adjustment, that strain did impact on survival.
So to take the headline message, if we can, from that, certainly in the second wave, the peak within January 2021 onwards,
Which is that very high
which
one.
was the highest peak of the pandemic, for both COVID and non-COVID patients, if you were admitted to ICU during that period, you had a greater likelihood of dying than if you were admitted during any other period. Is that correct?
So if you were admitted on a day where the strain was higher, yes, but that's likely during the wave, absolutely. And that's sort of done doing the most careful adjustment that we can for other patient characteristics. It's the best statistical methods that we have to study this phenomenon.
I'm afraid we're going to have to call it a day.
Yes,
Terribly
sorry.
Sorry, Professor Rowan. All rise. I'll see everybody at 10 o'clock tomorrow.